Okay. Right. So this is a post-op transposition who is having some rhythm issues, and let me see if Dr. Kong has any thoughts on what we're looking at here.
Good morning.
Bruce, welcome home.
Thank you. Just off first look, it looks like a very irregular rhythm. There does appear to be a P before auricularis, especially when I look at that lead 2 strip at the bottom. I'm trying to notice if the P waves look different in morphology at all. I think it does, but let me see if there's any association with the beats that come earlier. Yeah, it does appear to me that the P waves for the beats that come earlier are much wider.
P wave is wider, you're saying?
Oh, actually, they're coming earlier, so I'm looking at the T wave. I'm sorry, let me look again. It's hard to tell. I'm gonna look at B5. The beats that come earlier, I do think that there's a P before them buried within the T.
Okay, I agree with that statement. So what do you think we're looking at here?
And I don't think they're that different appearing, in which case I might call it AFib.
AFib.
Oh, actually, no.
And
the P waves are so clear, I wouldn't expect that in AFib.
I mean, look at these P waves. This looks pretty clean.
So they're let me, before I call it PACs, let me look at it just one more time.
Take your time.
Thank you.
No problem.
PC regular. Yeah, I might just call them PACs, and maybe there are times when they're happening in couplets. Yeah.
I agree. This patient is having PACs, and looks to me like the PACs are consistent in their morphology. It's hard to tell for sure, but so this patient basically is having some of the little runlets of EAT or PACs. So what would you do about this? Or would you do anything about this?
If he has a central line, I might check to make sure that it's not too deep.
The old central line theory almost never proves to be the case, but yeah, okay. It is not too deep. It's perfectly placed just at the SVCRA junction.
Is the patient stable with the PACs? I presume the patient would be, but.
Patient is very stable, is learning how to feed.
Postop DTGA, he's a 2-ventricle patient. I might just watch what happens.
Yeah, I think that's not unreasonable to just watch this patient and see what happens. This is yet one of many cases of atrial ectopy that we're seeing following congenital heart surgery. It's almost an epidemic in the United States and the world. I don't know why, though. Though, as you know, I have a theory it has something to do with Precydex. But anyways, yeah, I mean, it really depends on how much of this rhythm the patient is having. Now, it turns out that the patient was actually having short runs of EAT, quite a lot of them. This might even be the best strip that the patient had, meaning the least amount of EAT. So if you knew the patient was having, couldn't go a page of telemetry without having a 3 or 4 beat run of it, what then would you consider, Grace?
A beta blocker.
Yeah, I mean, usually that would be our first line therapy would be a beta blocker. And if that were to fail, what would your next options be?
I guess you could do amiodarone, but if it was just short runs, I wonder if I would still consider treating with amio.
I mean, amio is perfectly reasonable. It's a bit of a big gun for a small-ish rhythm, but not wrong answer for sure. Any other options?
The Sotalol, would you consider?
Yeah, you could use Sotalol. It's a reasonable option. Not quite as many side effects as amio. Any other options?
You could try procainamide. He's inpatient, but it's not really a great outpatient option.
That's right. So you could give procainamide, which would probably stop this arrhythmia, but would not, as you said, be a good long-term agent. So yeah, if the patient were sort of stuck in it and was becoming hemodynamically embarrassed by this rhythm, certainly procainamide would be a reasonable option. But this patient is not that bothered by it. Any other options? Well, you could use flecainide, right? That's used occasionally, or propafenone, an agent that we don't really use here. I don't even know if it's on pharmacy here. And then finally, one could use digoxin, right? School therapy might work, unlikely, but not an unreasonable thing to try. Some old timers would probably try a combination of propranolol and digoxin. When I first came to Columbia at a fellowship, that seemed to be the go-to for every bad SVT, and which was funny because I never saw a single patient treated in my fellowship with digoxin for any arrhythmia. So, but as I learned, they used to use very, very high doses of digoxin. They would go as high as 15 mics per kilo quite routinely. So, all right, thank you. All right, this is a 6-month-old who had a VSD closure, and we are looking at a rhythm strip that was kindly sent to me by a fellow, and I'm going to ask Tariq Zawani of Manhattan, New York, what he thinks is going on here.
Thank you, Dr. Bass. So I'm looking at the rhythm to try to see if we have a sinus rhythm or not. So
I should tell you that this is a tracing that a fellow texted to me. So this is the type of data that you will be given in order to make important decisions going forward.
Yeah. So I think, so initially there are like the beginning of the strip, there is some B wave before the QRS, but then I don't see it, and the QRS becomes narrower. So it looks like, I think junctional escape rhythm.
Okay. What did you say about the QRS being narrower? I didn't understand.
Yeah. So the length of the QRS.
To me, I think the QRS is pretty
Same.
similar throughout. Now, again, it's important to remember that we're looking at a single lead of the ECG, and it is very possible that in other leads, the QRS morphology may be changing. But let's assume for the sake of this conversation that on a 12 lead, the QRS is the same. So I would agree, this could be a junctional acceleration, right? That's the most likely diagnosis here, is that the patient is having a sinus rhythm
With
is competing, right, with the
yeah,
junctional rhythm. And you
yeah.
even notice, what do you notice is happening in the blood pressure tracing?
So the blood pressure tracing looks different in when the junctional rhythm happens, then the blood pressure tracing is different.
How so?
The wave is the length of the wave is shorter.
Mhm. I assume you mean that the blood pressure is lower? Is that what you're trying?
Yeah,
The
sorry,
length
yes,
of
yes.
the wave is shorter. I have
Yeah.
a term I'm not.
Yeah, it's
So yeah,
the
I mean, it appears like
lower.
also a little more irregular, right? You have some blood. There's some that are higher blood pressures. Some are much lower blood pressures. It seems like when we have junctional beats,
Mhm.
the pressure is a little bit lower. So there does appear to be some degree of hemodynamic embarrassment associated with this junctional acceleration.
Mhm.
So you're at the bedside there. What are you going to do about this? How would you manage this?
So I think because of this this is affecting the blood pressure, I think we should start pacing the patient at a rate that is faster than the junctional rhythm.
Okay, so what rate would that be?
So let's see. So I think we'll probably have to pace the patient at a rate of at least 140.
Yeah, I think that's probably right. We'll probably try that at 140. Now, would you turn it on at 140, make sure you're capturing and walk away from the bed space?
No, I think the main issue is going to be to make sure that the junctional rhythm does not recur when we start pacing, because if it's closer to the rate of the pacing rhythm, then we have to increase the rate of the pacing, because there is a risk of atrial flutter at that time.
You mean inappropriate pacing and not atrial flutter. I mean, you can always get no, I don't. No, that's not right. I mean, if it's not that you're at a risk for atrial flutter, what are you worried about if the rate starts to accelerate above the atrial rate? You're going to have AV dysynchrony, right? The ventricular rate will get faster than the atrial pacing rate.
Mhm.
Theoretically, the patient will just sense the A because they might be VA conduction and might just sense the A and not pace. So in other words, you're looking to see that that you remain in a paced rhythm, not competing still with the junctional, because junctional rhythms can accelerate. It depends usually on how far out from the surgery you are.
Mhm.
Typically, patients who have surgery, like if we're on post-op night 0 and it's 3 hours after surgery, we would have to be concerned that the patient's junctional rate will eventually get fast enough to overtake the sinus rate, and or even an paced rate. So yes, I agree that pacing at 140 based on this particular tracing ought to be fine. But I think what you're trying to say is that if the heart rate gets faster, if it goes to like 160, you would have to adjust the atrial pacing accordingly. Is it a guarantee that if we pace the atrium at a rate faster than the junctional rate, that the patient is going to get better?
It's not a guarantee.
Well,
Because
that's easy.
I mean, it may persist, and then we may have to.
Well, the point I'm trying to make,
Yeah.
Tarek, is that apacing, apacing does not always make the patient better, even though you may have AV synchrony. AV synchrony at 140 may not be better than AV dysynchrony at 125. We just don't know. You would expect it would be better, probably most of the time it's better, but sometimes it's not. Sometimes you start pacing at 140 and there's inadequate filling time. Or maybe let's say this rate was at 140 and you had to go at 160. It would not be unheard of that you do that and the patient actually has, gets worse. Let's say you're in that circumstance where you're pacing and you're not really a whole lot better hemodynamically. What else could you do?
Think probably using them, like treating the patient with the non-arrhythmic.
Well, how would you treat it? Let's say it kept getting, so the easiest thing would be that you just pace at 140, the patient's junctional rate stays this rate, you're able to overcome it and the patient does fine. And eventually, as you know, the natural history of junctional rhythm after surgery is that it resolves. But let's say it does not, that the heart rate starts to accelerate, that you find yourself having to go back to the bedside 3 or 4 times and increase the pacing rate. You're now pacing at 170. You're concerned because it's the 3rd time you've had to increase the rate of pacing. The patient's blood pressures are marginally less good. The filling pressures are a little higher. Your urinary output is less than 1 cc per kilo per hour now, and it used to be 3. So how are you going to get this junctional rhythm under control?
So
there are only 2 main options.
Yeah.
We've discussed.
So maybe I don't think we can think about a permanent pacemaker then.
A permanent pacemaker? Why would we use a permanent pacemaker to treat a problem that we know has a natural history of going away in a few days?
Yeah. So
you had mentioned the idea of treating the arrhythmia with drugs.
Yeah.
Is there a drug you could use?
Yeah. So maybe we can use then procainamide.
Right. Could use how is there anything else you'd have to do if you're using?
Yeah. Yes. We need to cool the patient to 35 degrees.
Right. So we would cool the patient, and the cooling alone might work. So I would probably first cool the patient. Now, as the ICU cardiologist, a goal of yours, anything else you would do if you decided you were going to cool the patient?
So I think we need to make sure that like decrease the if the patient is on catecholamines like epi, we need to stop that too.
Right. We would lower the catecholamines if tolerated.
Yeah.
Sometimes you're caught within a rock and a hard place because you're hypotensive and you're still on inotropes. But okay, I agree with that statement for sure. Anything else you would do? What about you cooling the patient? Anything you need to do in someone who you're cooling?
We need.
What would happen to you if I cooled you to 35 degrees? How would you feel? Would you be comfortable and say this is a delightful feeling, or would you be shivering and freezing and angry at me for doing
sorry I think we need to have the esophageal probe, and then probably then also we need to, the patient has to have a secure airway then.
Okay, well, you could not cool somebody unless they were intubated. Okay, because why is that? How do we cool patients?
So we have the cooling blanket, and then
right. So if a patient is awake and is sitting up, you can't really effectively cool them on the blanket requires that the patient is lying flat on the cooling blanket, which a awake child will not do. Is there another reason
sedation?
Why not want to? Yes, sedation.
Sedation.
Don't want to. It's very uncomfortable.
To
be lying on a very cold blanket and to be shivering. So you want to heavily sedate the patient. Also, in the old days, we used to say that you should paralyze all these patients because shivering is a inefficient use of cardiac output. In the present era, there's been a push to move away from paralyzing patients and just to so heavily sedate them that they don't move. On that basis, on the theory that paralysis is bad for fluid and movement so I don't know if I agree with that, but whatever the case may be, we typically would very heavily sedate somebody who is being cooled. You must be intubated. Okay, let's say
And
that. Yeah, go
sorry,
ahead.
you said like anybody that's cold has to be intubated. I mean here, okay.
Yeah. If you're going to actively cool them to 35 degrees, yes. If you want to give someone Tylenol and keep them in a normothermic but low normothermic range, no. But if you're actually trying to cool someone to 35 degrees, you cannot be awake for that, unfortunately. I guess I could imagine maybe you could do this with Precydex, where people can, right, with Precydex, one of the benefits of that agent is that you can continue to, you don't lose your respiratory drive as much, which is why critical care physicians like to use it, particularly patients who are extubated immediately after surgery. It's a way of sedating, but still maintaining ventilation. But I've never seen it done for that. What about Precydex in general for the treatment of this? Or its use in this? Does it have any role in the treatment of jet in a post-op patient?
So it gained a lot of popularity and is the one agent that's used more. And the only caveat is that it may cause some bradycardia and also lower blood pressure.
Right. So actually, Precydex is fairly commonly used as it's often I would say it's the sedative of choice for somebody who is having jet, because Precydex itself can cause bradycardia and slow junctional tachycardias. So in some hospitals, the first thing that they might do once they've made the diagnosis is switch the sedative to Precydex. Although in the present era, most patients are already on Precydex, but maybe increase the dose of Precydex. And then finally, the last option would be to use intravenous amiodarone, another alternative. And the benefit of amiodarone would be that you don't need to cool the patient, you don't need to paralyze or sedate the patient for that. The disadvantage is that amiodarone doesn't work very well for jet, despite the fact that everybody seems to believe it does. There's actually a very marginal evidence that it is particularly helpful. It does work, but it probably works less well than cooling and procainamide. And it has a series of morbidities associated with it, including can cause chemical burns. It can also cause cardiovascular collapse, particularly in young infants.
Yeah.
So it's a good agent, but if we don't have to use it, I would generally not want to use it.
Yeah.
All right. So this is an intracardiac tracing from a patient who's in sinus rhythm. I'm going to ask Dr. Perna Bonsall what she thinks is wrong here. This is from a 2005 EP conference I gave. 16 years later, still just as fresh as it was then. A chestnut, a genius.
Good morning, Dr. Bass. So I'm looking at the surface EKG lead. I see the QRS complexes, but the P waves are not so clearly seen, at least in lead 1. Then I do get a hint of it in lead 2. 3, maybe a little bit, yeah. 4, AVF, no, V1. Okay, so 1 and so I do see P and QRS. And then that corresponds to the high RA catheter. And then I think we have the HIS catheter here.
Yeah.
That is noted as HBE. And then we have the RV. So we see
HBE, just for everyone to understand, stands for His bundle electrogram. That was a common term that was used in the old days.
Okay. And then A wave is followed by A, H, and V.
The author was kind enough to label for you.
Yeah.
for you.
which does correspond to the surface electrocardiogram. The second beat,
Mhm.
the A wave in the his catheter is fine, but the HRA, it's not similar to how it's in the other two beats preceding and succeeding it.
That's true, but I wouldn't read much into
Do,
that because
okay,
you look in the HIS, I think you would agree that the HIS A all look the same.
yeah, the other.
Also, I think if
fine.
you look at the surface electrocardiogram, I think you would
Mhm.
agree that the P waves look pretty much the same. So I can't explain to you why this RA electrogram, you're right, it does look different than the other two, but it probably has something to do with just movement of the heart in the chest with the catheter sort of.
What's the age of the patient?
The patient is 12.
Age interval is sort of borderline.
Mhm,
It's fine.
that's right. And
The
you don't need the patient's age to answer this question, or else
yeah.
the question writer would have offered it to you. But yes, for the sake of conversation, it's 12. Yes.
Yeah, and then also the HV interval is 95, which is long. So there is a delay in conduction from his to ventricles, I would say.
Yeah. And so the what is a normal AH and what is a normal HV interval per Nabon?
So AH 120, I would say 120 is the sort of like the borderline high. 120 is the upper range for the AH interval.
Mhm.
And then HV, I would say 50, less than 50.
Right. So the HV, you're right. 35 to 50 is a normal HV interval. AH, you can actually go up to about 150. You're right. When you're in the 120 to 150 range, you're definitely at the highest range of normal. And you certainly, if you were about to ablate somebody, it would not make us happy to see that the baseline AH is 130 milliseconds. But this patient clearly has His-Purkinje disease, because the HV interval is so long, 95, and also has borderline AV node disease. Remember that the AH interval is supposed to represent which conduction in the heart, Perna?
So that's from the atrium SA node to the AV node. So that's the PR interval corresponding to your surface EKG.
Well, the PR actually corresponds to the AH and the HV, but the AH is supposed to represent the AV node. I'll remind you that you notice that we never in the EP lab have an electrogram for the AV node, right? We have an A, we have an H, and we have a V, but we never, you never hear us say, oh, there's the AV node signal. And that's because the AV node does not actually make a signal on standard intracardiac catheters. Now, there's a wonderful old cardiologist at Boston Children's who's long retired named Walter Gamble, who used to say that if a patient were in a completely electrically neutral room, you could record signal from the AV node, but as I've never done that nor seen that done, I can't speak to the veracity of that comment, but I do think it's true to say that generally speaking, we can't record the AV node. So we use the interval from the A to the H as a surrogate of AV nodal conduction, with the A in the His bundle being close to the AV node and not to the SA node, and then the H being obviously just on the other side of the AV node. So presumably the time it takes to go from the RA to the His should reflect the time it takes to go through the AV node. And similarly, the time it takes to go from the His depolarization to the ventricular depolarization should be His-Purkinje conduction time. And so in this patient, the patient has real evidence for His-Purkinje disease, but also some AV node disease. In a post-op patient who has heart block, would the block typically be at the level of the AV node or the His-Purkinje system in someone who, is going for a pacemaker because on post-op day 10, they are still in complete heart block following surgery? Dr. Bonsall, are you still there?
Sorry, I was muted.
All right.
I'm saying that it will be the conduction to the AV node from the A.
Actually, it's the His-Purkinje system that's usually affected by surgical heart block. In olden times, patients used to be studied when they'd have heart block after surgery. Not actually sure why they did that. I think it was for people who had maybe second-degree block, and they were trying to make some predictions regarding the recovery of the conduction. We don't do that much, almost at all anymore. But most of the time, surgical heart block is His-Purkinje disease. So it's a pretty serious type of an injury. And generally speaking, injury to the His-Purkinje system is considered a more serious, more real and more permanent type of injury than AV nodal conduction block. Okay. Move on to the next tracing here. So this is a teenager who has myocarditis and some heart block. And my question is, what is going on here? And I see that Dr. Duong is with us today. Sunny, you want care to offer a thought on what's going on here in this tracing?
Sure. So heart rate is low, around 50 to 60, so bradycardic. There does appear to be a P before every QRS. The P wave, PR interval is lengthening. And interestingly, the QRS morphology changes when that P wave really jumps out.
Yes.
And so my first inclination is that there is some first degree heart block going on here. It's kind of maybe variable. The other possibility is this could be winky box, but it's we're just missing the actual dropped beat. So the PR is lengthening, and then it actually doesn't drop on this screen. But if it ever dropped, that would make me think this is a winky box conduction.
What do you think about the differing QRS morphologies, though?
Oh yeah. So I mean the ones that appear to be conducted are, or sorry, the ones that appear to be closer to the P intervals are wider, right? So I guess that would be ventricular in origin. And so
I should just mention, Sonny, it was cut off on the side here, but this is me measuring the PR interval at 313 milliseconds.
Right. Okay, well then I think maybe an alternative theory could be that this is actually an accelerated ventricular rhythm that's coming in before the native atrial conduction gets through the delayed AV node. So this is maybe a competing accelerated ventricular rhythm in the setting of first degree heart block.
Yeah, I actually I think you're right. That's how I would interpret this. I think that, well, what we're seeing here on the left-hand side of the screen is probably isosynchronous contraction of the atrium and the ventricle, making it look as if you look carefully, you see that the PR interval is sort of varying from beat to beat, and it isn't exactly lengthening in a pure Wenckebach manner, right? If you look at this PR, I think you could see in your mind's eye that this PR interval is actually marginally shorter than this PR, and I think for sure this PR is even shorter than that one before we start seeing longer ones. So I actually think that the P waves are just beating at a rate that is similar to the ventricular rate. And then when the P wave comes in just early enough, or there's enough time, it starts conducting. And so I think this is isosynchronous contraction of the atrium and the ventricle with a ventricular rhythm, followed by conduction with a very long PR interval. So this would be a somewhat worrisome finding that the patient is having a lot of ventricular escape rhythms. Suggests the AV node is definitely taking a hit from this example of myocarditis. Ultimately, what would you expect would happen so the mother is a physician, she's a dermatologist, and she's at the bedside, and she's heard the doctors talking about lots of evidence for AV dissociation and very profound first-degree heart block. What would you advise the mother? Should she be calm and optimistic, or should she be nervous that the Medtronic people are coming?
Well, I would be nervous in the setting of ventricular ectopy in myocarditis. So if it were any kind of faster ventricular ectopy, I'd be, very concerned that the patient could have a VTAC or VFib arrest. And then I guess if your question
again,
is,
remember that this is not a very fast.
Right.
This rate is at like 50 or slower, but yes, that's always a possibility. But do you think this patient, what do you think is the odds this patient's going to a pacemaker?
I see. Well, I don't know, but I do know that myocarditis is a inflammatory condition that is resolvable, right? So I think that I would take a watch and wait approach to see if there's return of a more normal AV node conduction. Basically, I think it can get improved.
Yeah, that's exactly right. Most of the time, myocarditis conduction abnormalities will resolve. It's not 100%. And it's interesting to note that there are patients with, we see people with myocarditis, and in the vast majority of cases, every aspect of their heart involvement improves. Their function recovers, their conduction, which can often be affected in the setting of heart inflammation, will almost always resolve. But there are rare patients who are left with poor function and conduction abnormalities that are persistent for the rest of their lives. And we've generally not understood why it is that happens. Why are there patients? Why do the majority of patients seem to resolve and have complete resolution of all of the problems that we see in myocarditis, even very badly affected acute myocarditis, and that other patients, rare patients, do end up going to transplant or having very bad conduction that persists, requiring pacing permanently. And it's not very well known, but there was a recent paper out of Bruce Gelb's lab or group with Amy Kontorovich that we reviewed on the podcast about 3 or 4 months ago, in which they identified a lot of cardiomyopathy genes in patients who had myocarditis and never really recovered, always had bad function afterwards. And the question is whether there is a genetic susceptibility to worse long-term function amongst some patients who have myocarditis randomly, and that maybe the myocarditis is just making it more obvious to us that there is a genetic problem there. And a lot of known cardiomyopathic genes have been found by Amy's laboratory in patients who had bad outcomes following what seemed to be fairly routine myocarditis. So the answer is I would tell the parent of this patient, if I was sitting there, that there's good reason to be optimistic that this could resolve, but that the jury is still out. We'll still have to wait and take a wait and watch approach. So we would definitely drag our feet a fair bit on this in the hopes that it would recover. And I think with that, we'll stop for today. Thank you all very much. I will see you in a short while at Sign Out. Hope everybody has a great day today. Be well.